صبركم يقوينا لنحد من انتشار فيروس كورونا في مملكتنا الحبيبة.
ربنا يقدرنا على خدمتكم وتوفير كل احتياجاتكم من العلاج.
نصنع الدواء ليساعد على الشفاء.
ومثل ما عودناكم احنا دايما معكم.
بعزيمتكم ديارنا بعون الله محمية.
خلينا نبقى كلنا سالمين وبعون الله الأزمة حتمر.
مثل ما عودناكم احنا دايما معاكم.
خليك في بيتك واحنا بالمستشفى، ان شاء الله نسهر على راحة كل مريض.
بيتكم أمانكم، لا تفرطون بصحتكم، هي ثروة ونعمة.
خليكم في البيت بعيد عن الاختلاط.
السلام عليكم ورحمة الله وبركاته. Thank you, Professor Abdul Jabbar, for this kind introduction. Good evening, ladies and gentlemen. First of all, I would like to thank the organizing committee and Tabuk Pharmaceutical for this kind invitation. It's my real pleasure to be with you in this successful webinar for this talk here tonight. So in tonight's talk, we're gonna start with the importance of hypertensive disorders in pregnancy, and then we're gonna go through the latest definitions and classifications according to the latest guidelines. I'm going to touch base on the expectant management versus interventions in those cases with preeclampsia with severe features, and how to time their delivery, and how to choose the antihypertensive medications and to target the blood pressure in order to reach the most promising or successful outcome that is possible. And then I'm going to conclude with the long-term follow-up plans. So the real concern for hypertensive diseases in pregnancy is that hypertension is the commonest medical disorder in pregnancy, as it occurs in about 4 to 5% of all pregnancies around the world. And the impact of this disease is the responsibility of this disease in giving us more than 500,000 preterm births yearly. Not only that, but around 60,000 maternal deaths annually from this catastrophic disease. So the hypertensive diseases in pregnancy are approximately the leading cause in 1/4 of the maternal deaths around the world. So the latest definition of preeclampsia according to the ECHO 2019 is that it's a disorder of pregnancy associated with new onset hypertension, which occurs most often after 20 weeks of gestation and frequently near term. Although often accompanied by new onset proteinuria, hypertension and other signs and symptoms of preeclampsia may present in some women in the absence of proteinuria. So the criteria now to diagnose preeclampsia is to have a high reading of blood pressure, and to have a reading of a blood pressure of 140/90 or more in at least two occasions 4 hours apart after 20 weeks of gestation. However, if the blood pressure readings were at a level of 160/110 or more, and we had to initiate the antihypertensive treatment, then we apparently do not have to wait for 4 hours just to diagnose. So having a high readings of blood pressure plus one of the following: either to have a proteinuria with the high blood pressure, and the most commonly used nowadays as a definition for proteinuria is the protein creatinine ratio of more than 30 milligram per millimole. So either proteinuria or low platelet count of less than 100,000, having high serum creatinine being doubled in the concentration, or higher than 1.1. Having a liver enzymes at a level of twice the upper limit of normal, pulmonary edema, or having visual or cerebral symptoms. One of those plus the high blood pressure is the criteria for the diagnosis of preeclampsia. In this box, if we had our patient with one of these, then it is considered a severe feature. Of course, a blood pressure of 160 over 110 in 2 readings, 4 hours in between. However, if we had to start the antihypertensive medication, then apparently we don't have to wait for 4 hours. And having thrombocytopenia with a platelet count less than 100,000, liver enzymes of twice the upper limit of normal, or having a right upper quadrant pain that is persistent and non-responsive to medications, or having a renal insufficiency with a high level of creatinine, all those without any alternative diagnosis with a new onset, having a pulmonary edema, or as mentioned earlier, cerebral or visual symptoms. The Canadian definition is actually quite, more simple than the American one. So they simply defined the preeclampsia as a gestational hypertension with one or more of the following. So it's a gestational hypertension with new onset proteinuria, or an adverse condition, or a severe complications. So what are those? So here in this table, we can find in the left side the adverse conditions that can be accompanied with preeclampsia. So they classified the findings that can come with a higher blood pressure in order to diagnose preeclampsia into either adverse conditions, and those include headache, chest pain, oxygen desaturation, and the list goes on with elevated white blood cells, right upper quadrant pain, etc. And the fetoplacental changes, including IUGR, oligohydramnios, or abnormal umbilical artery Doppler findings. So these are the adverse conditions that can be associated with preeclampsia, and just be careful that I didn't say that those are the severe features. These are only the adverse conditions, and these are not necessarily indicating a right-away delivery. So on the other hand, the severe complications that indicate a prompt delivery might include eclampsia, PRES, blindness, Glasgow scale less than 13, stroke, MI, pulmonary edema, acute kidney injury, and the list goes on with an INR more than 2, or fetoplacental changes, including, of course, stillbirth, or having an abnormal A wave in the ductus venosus Doppler, or having an abruptio placenta with an evidence of maternal or fetal compromise. So one of those is enough to indicate a prompt delivery, as it is considered a severe complication. So the real dilemma is when we have a case with a severe feature occurring before 34 weeks. Either we want to go with an expectant management, or if we want to go with a delivery right away. So when we want to consider an expectant management, it is very crucial that we choose our cases really carefully, and we make 100% time that they are fulfilling our strict criteria. So in order to proceed with an expectant management, you have to make sure that your patient does not have one of those mentioned findings. And those might include, of course, uncontrolled blood pressure, of a blood pressure readings of 160/110 or more. That is not controlled with your antihypertensive medications, or persistent headache that is not going away, or if she is having deteriorating visual disturbance, stroke, MI, or HELP syndrome, pulmonary edema. So all these are findings that preclude, and these are contraindications for any kind of expectant management. So one of those, deliver just right away. Fetal indication for delivery right away and not even considering expectant management might include abnormal fetal heart rate in the CTG, of course, if the baby is dead, or if there was a lethal anomaly, lethal congenital anomaly, then obviously we don't want to wait and we will just presume with delivery. Or if we had a persistent changes in the, or persistent reverse in diastolic flow in the umbilical artery Doppler. So minor changes in the criteria of expectant management, and some small changes between the American and the Canadian guidelines. Like, for example, the Canadian did not say that HELP syndrome is a necessary for right away delivery, and the Doppler changes that Canadian, they mentioned that you can go with umbilical artery Doppler, you can continue still by 1 or more 2 days or 3 days by good conservative management with good observation day by day. Of course, when we want to consider this, we have to make sure that we have the right capabilities and resources, and those include MFM service that is available 24/7 in a tertiary center and a good in ICU. Other way, if we don't have that, then of course we will go with the traditional saying, severe is delivery. So a Cochrane review found out that when those cases who were fit for expectant management before 34 weeks, who delivered after an expectant management and going on a basis of a day-by-day management with maternal fetal medicine services and multidisciplinary approach, they got the benefit of the conservative management, and they got the benefit of advanced gestational age and better neonatal outcome. So we can say that this protocol over here that I just created, we can say that this protocol can be used in order to manage a case of acute preeclampsia or preeclampsia with severe features. So we can divide our patients into either the upper group or the lower group, the upper group or the lower group. So whenever we have a patient at or beyond 34 weeks, or if we had a patient who is in labor already, or if she ruptured her membrane, then obviously we are gonna deliver right away. If the patient was less than 34 weeks, then simply we either go with this approach or that approach. So if she was less than 34 weeks, then we'll either go with the upper approach, which is, if she is less than 34, severe feature of preeclampsia, we could not stabilize, or if she had a complication that is mentioned to be a finding that indicate an immediate delivery, then of course we will deliver. Or if we could stabilize our patient before 34 weeks and she was carefully fulfilling the strict selection criteria that we choose, then we can consider expectant management, provided that we are in a tertiary center with an MFM service covering 24/7 and a good NICU. And our aim will be toward timing of delivery reaching a late preterm gestational age between 34 to 36 and 6. Some other studies, like this large multi-center clinical trial, found that the expected management that we are talking about is not only not beneficial, but might be harmful. Because the MIXPRE study, they found that there will be no neonatal benefits with expectant management of severe preeclampsia before 34 weeks. In fact, a conservative approach might increase the risk of abruption and small gestational age babies. So they argue here, so that this is totally different than the conclusion of the Cochrane review that found that those who were fit for the expected management got the benefit of better neonatal outcomes and a better advanced gestational age. But they argue here is that the capabilities and the resources are the key. So whenever we have a good tertiary center with a high risk floor taking care of only those cases with maternal fetal medicine service 24/7 and good NICU resources with a very ready multidisciplinary team in taking care of those cases, taking care of any complications that occur at any point, then at that point, our patients might get the benefit of the expectant management. So choosing the antihypertensive agent is quite standard. There's no difference, throughout the guidelines and throughout the years. If you had a patient with blood pressure of higher than 160 over 110, then you might want to start with one of those parenteral agents, including labetalol or hydralazine as the protocol dose, or you might want to start with the nifedipine oral, the immediate release one, and you might want to be taking some precautions, the usual one, like for example, avoiding the labetalol in cases with asthma or in those patients with cardiac complications. Hydralazine, just be careful when you use that medication from the sudden hypotension and headaches, and with nifedipine, also might want to pay attention to the reflex tachycardia and headaches. Canadian guidelines are similar to the American ones in terms of those medications. The first line medications with high blood pressure higher than 160 over 110, same medications with our target toward lowering the blood pressure to a level of 130 to 155 systolic over 80 to 105 diastolic blood pressure. This interesting study, which was published in the Lancet last year, was looking only on treating those patients with severe hypertension by using oral agents. So what they did is that they randomized around 900 patients who were enrolled in the study, and then they subdivided them into 3 groups. One of them were treated with nifedipine orally, and the other one with labetalol, and then methyl dopa group. All of them are oral medications were started and initiated for patients with acute elevation or severe hypertension. So the primary outcome was looking into starting those 3 medications and they wanted to reach this goal, lowering the blood pressure to a level of systolic 120 to 150 over a diastolic 70 to 100 within 6 hours with no adverse outcomes. So they found that nifedipine was the superior medication over the other two drugs in reaching the primary outcome of lowering the blood pressure and no adverse outcomes within 6 hours by a percentage of 84. And the reason why did they do that is, I mean, why are we just looking into oral agents? Is that when you or anybody is working in a rural area and you don't have enough capabilities, or if your patient doesn't have an IV line access, then you might want to consider going with the oral agent for treating severe hypertension. So now we know that nifedipine is still the first-line agent, and as said earlier by the American and Canadian guidelines, it still can be considered a first-line agent in lowering the blood pressure that is acutely elevated. This study from California, which was published last year, looked into the maternal deaths, which caused by the hypertensive disorders of pregnancy and per se, specifically preeclampsia. So they had 54 maternal deaths from preeclampsia, and they looked into them and they found that 33 of them had strokes, and that was the leading cause of death for those cases. And they looked into the blood pressure readings for those patients, and what they found is that interestingly the systolic blood pressure was more associated with the elevation, with the prediction of the cerebral events. So when we say acute onset severe hypertension, what we mean by that is a blood pressure of 160 over 110 for more than 15 minutes. And the real risk with that is the risk of stroke. This is what we are afraid of. And whenever we have a patient who is symptomatic or with a blood pressure of 160 over 110 or more, then of course we're going to manage with the first-line agents, including levodopa or hydralazine or oral calcium channel blockers. When we have no worrisome symptoms such as headaches or chest pain, etc., and the blood pressure is between 140 to 159 systolic, then other oral agents can be considered. So of course, the definitive treatment is always the same, delivery. So when we say that, our main goal is to start with the maternal stabilization. So delivery first, your first goal is stabilize the patient, because the last thing you want to do, believe me, is to intubate a patient and to take her for a C-section and intubate her and while she is unstable. No, she might not wake up again. So stabilize first, and we know that the risks subside in the hours after delivery. Of course, the fetal heart rate should be monitored continuously during this acute therapy. Of course, when we say acute therapy or acute management, we're talking about management as soon as possible, within 30 to 60 minutes of confirmed severe hypertension, either by IV labetalol, hydralazine, or oral nifedipine, the immediate release. So these are the first-line agent worldwide. The second line therapy, however, when we do not reach our target goal of lowered blood pressure, which is rare actually. So in these rare occasions, when with not reaching the target blood pressure, then we can go with nicardipine, ismolol, or furosemide, nitroglycerin, nitroprusside, etc. But of course, when we reach this point, we should be already have involved the other teams with a multidisciplinary care, including the ICU and our colleagues from the internal medicine services. Of course, furosemide with a debilitating edema, there is no enough data, but it should better to be avoided. Nitroprusside should be always kept as a last resort, keeping in mind the risk of fetal cyanide poisoning. Magnesium sulfate is a never substitute, of course. And I know that there's always saying that magnesium sulfate with nifedipine, since they both are calcium antagonists, then you cannot give them together. But there was a large retrospective study which solved the issue, and it is safe to go with magnesium sulfate together with nifedipine. And it was concluded from that large retrospective study that there was no increase in the risk of neuromuscular blockage nor sudden hypotension. So it's okay to go with those two. Just it is recommended to monitor the maternal heart rate as well when we start or when we treat with those medications together. So always there is a message as well in this whole management, and this message is not to keep ourselves in a tunnel vision toward managing preeclampsia. The reason why is that especially when the case is presenting atypically, there might be another reason like acute fatty liver or malignancy or vasculitis, or even, I mean, not pregnancy related like pheochromocytoma or some medications, etc. So just keep those in mind as well while you are managing those cases. So when we say acute therapy, the Cochrane review concluded that the choice of antihypertensive medication should depend on the clinician experience and familiarity with a particular drug. So keep those handy, those protocols for hydralazine, labetalol, and nifedipine, keep them handy, and the healthcare providers are, I mean, they are recommended to have those handy in their working area and in the birthing unit, just to be ready for a prompt administration of antihypertensive medications any time of emergency. So our management and our mission does not stop there. Our mission continues to where? Continues to refer those cases and to consult our colleagues after managing all this. In the future, we know that those patients are at a higher risk of developing cardiovascular disease, CVA, peripheral arterial disease, cardiovascular mortality. So our mission does not stop by only managing that, but please refer them for future annual checkup as well. And this will bring us to the end of our talk tonight, and I'm open for any questions. Thank you.
شكرا يا دكتور أيمن على very interesting, nice presentation, and we will try to find some of the questions. Please, for people who want to ask questions, they can go to the chat and write their question. I have a few questions here. We will start with them by the time we get some more questions. For Dr. Hisham, what about polyhydramnios in GDM? Does it occur, and does it really cause a problem, or no?
Yes, polyhydramnios is one of the diagnostic, sometimes features of GDM. Something that we recognize very well, and the mechanism actually behind it actually is not very well understood. However, it has something to do with the placental function, whereas there is some dysfunction at the level of the membranes lead to the leak of fluid and accumulation of the fluid around the fetus. Is not related to the GI function at all.
Very interesting. For Dr. Ayman, did we really decrease maternal mortality with conservative or expectant treatment for and management for hypertensive patients?
Yeah, so this is a really excellent question. And as I mentioned in the slide, so there was a Cochrane review that mentioned, yes, we reached a better outcome. And even the mortality, yes, it was decreased from reaching a higher gestational age, but that was only when we are talking about some specific centers with high-risk floors and services and NICU capabilities, because honestly, some studies are showing, and this is also a message for everybody, sometimes it's harmful, by the way. If you are not very expert in this field, just don't go around it, because if you did not choose your patient carefully, you might cause harm, such as, and it was proven by the studies. It's not just I mean, it's just not just a guess. There was a study that mixed breed study that I showed. It might cause it was increased risk of abruptio placenta and morbidity and mortality. So all of them are increased when we are not carefully selecting the criteria. But on the other hand, if we had the right capabilities and resources, then yes, we are decreasing.
Very interesting. The maternal mortality, I mentioned in the beginning that it's has a triad of high blood pressure, infection, and bleeding, and the FIGO and WHO for the last 20 years, they're trying to decrease maternal mortality, and there is a program all over the world to decrease maternal mortality, and it has been decreased from 500,000 person die every year to maybe 300 or maybe less than 300,000. And
True.
interestingly, that hypertensive, still 60,000 of them are due to hypertension. I mean, the bleeding, they solve the problem with modifying blood banks and availability of blood and thrombosis. They started with the heparin and Clexans and prevention of thrombosis, and it worked very nicely. Hypertension still a major issue in maternal mortality, and this is why there was so many study about whether you deliver or you do expectant management, or whether. And I think it's an important message today. You give people important message for expectant management, which can be useful, decreasing maternal mortality, decreasing prematurity, and at the same time you saving a lot of not only resources but also you saving money for the institution who can do that. Yeah. Maybe the other question, I'll go to Hisham. Tell us about, maybe you mentioned it quickly, but tell us about how can we use oral hypoglycemic in patients of diabetes. I know people they now a change in modality of treatment, diet, oral hypoglycemic, and insulin. In the beginning, I remember when we were resident, it was either diet, there was no oral hypoglycemic. Can you emphasize this more, because I want this message to get to the people.
Very well. It's a very good question. And
can you hear me, Asha?
I hear you. Yes. Can you hear me? Okay.
Yes, I can hear you very well.
Actually, I didn't touch on the management here in my presentation, but definitely we have now a solid ground to stand on for the use of oral hypoglycemic in gestational diabetes, as well as type 2 diabetic pregnant patients. We have actually secured the part which usually used to be afraid of, which is the teratogenicity of oral hypoglycemic. Thousands and thousands of patients been using it, and without any increase in incidence of fetal anomalies. Even the control that, we have studies showed that we have even better control of gestational diabetic on oral hypoglycemic than insulin, with more patient satisfaction. Patient doesn't need to prick herself with needles. So it's very convenient and give you good control of her blood sugars, and the outcome is excellent.
Very interesting. I will go to Dr. Ayman. Myself, when I treat patients with oral hypoglycemic, I get annoyed, and I think that it maybe take long time, and maybe I cannot treat her blood pressure, control her before I will be satisfied to keep her for another day or another week.
So are we talking about
medication, oral medication
for the blood pressure?
How long would this take to work, these medications?
Yeah, so each medication, of course, each medication has an onset and a half-life. So it depends on your medication. So if you are treating with labetalol, so you're just talking about hours in controlling the blood pressure. So we're not talking about days or weeks. It's just one by one. So you can know immediately right away from starting the. It's not an accumulative thing. It's an immediate action. So if you did not success, so for example, if you started with oral labetalol or even Aldomet, the most common ones here. So if you did not succeed right away, so you just go with the increasing the dose until you reach the maximum dose. So I can't say. It depends on each patient and her blood pressure. We don't start with right away highest dosage. Each medication has its dose. Yeah, it's the highest level or highest dose. So we don't go right away, because even the fluctuation in the blood pressure or this sudden hypotension might kill the baby, might do harmful effects, might do even a rupture placenta. So we want to go gradually, and that's why we are targeting only our blood pressure, not to 120 or 110. No, we are targeting our systolic blood pressure. We have an American and Canadian guidelines. So the Canadians are saying you target your systolic blood pressure into 130, systolic 130 over 150, and the diastolic between 80 to until 100. So you have a wide range, and it's not too low. So and actually it depends on each patient, but it should be like a day-by-day thing.
But for example, methyl dopa, I know that it will take more than a day or two to start working. When you mentioned that methyl dopa has been used even in a randomized control study.
Yes.
Is this true? Is it
but there,
now?
no. It depends. In the randomized trial, it was only for acute management, and the target was to reach a successful lowering blood pressure within 6 hours, not more than that. So if it's more than that, then it's not successful. So if you want to if you want to look into the studies, it's mentioned just 6 hours. And if you didn't, then it's just not successful in doing that. Most of the studies are actually going by the frame of the first 6 hours. So if you didn't, and we're talking about your target of blood pressure. So when you target, your patient of 200 systolic, you will not aim towards 110. You will just go like step by step. If your patient was 150, then you might want to go to 120 or 130. And I mean, usually what we do, I mean, there is no guideline for that, but we give ourselves 24 hours to experience the medication. And then after 24 hours, like after the patient, to put her in all the stressors and all the environment, including her sleep, her eating, her normal life, her going to work. So after all that, we can say, and sometimes we can also, I mean, if she came to me during the weekend, I might tell her, go to your work, and then I want to see your blood pressure when your boss give you a hard time. And I mean, it really depends. It's not like 1 + 1 = 2.
If you allow you, Hassan, I want to ask Ayman regarding. I know you, دكتور أيمن, كيف حالك؟ طيب.
أهلا 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 يا برو.
I enjoyed your talk really, and I know you were talking about the acute management of PET, but what about simple cases that you put her on oral medication and send her home? My question is regarding home monitoring of blood pressure. Is it something reliable, something that we can trust our patients to use?
Yeah, so here we're talking about education, we're talking about the machines, we're talking about the calibration, we're talking about, I mean, we have even in the Fetal Medicine Foundation group in their tutorial and in their course about preeclampsia, they always mention that you want to educate your patient and then you want to calibrate. You don't want, for example, an obese patient using a smaller cuff, so she will get a higher false misleading result. This is one factor. The other factor, sometimes we have the other way around. We have a white coat phobia. So the patient comes to the hospital and she has a higher reading, and she goes home and she sends you through WhatsApp her blood pressure, and it's beautiful. And just she comes and see you and she gets scared from your face or something, and then she has a high blood pressure from the nurses and from the environment. And actually that is a category of one of the hypertensive disorders in pregnancy. It was added to the Canadian, that it's a white coat hypertensive disorder. So amazing. I'm really glad that you asked this question, because when we do the monitoring for blood pressure, first we educate our patient, and then I usually ask them to bring the monitor, and I really compare in our setting and her monitor, and we teach them, because sometimes, you know, in the Fetal Medicine Foundation there is a way to monitor your blood pressure. You don't you want your arm sitting like that and supported and blah blah blah. So it's we have to teach them. So we teach them, and then if I suspect that they are not monitoring well after that, sometimes, I mean, rarely, we tend to admit if the patient was not, I mean, if the blood pressure was not controlled, and we felt that it's necessarily, but it's really rare nowadays. I mean, most of our ladies are well educated nowadays, and they know how to monitor them, and we are reaching good outcomes, honestly.
Good. Hisham, maybe this is a question away a little bit away from our topic, but maybe it's important. People asking about obesity and infertility. And we know that although people, they might be very obese, they might get pregnant very easily. Others, they might not get pregnant, and they go for weight reduction. And once they have good weight reduction, especially now with the modern way of exercising, the modern surgical approach to reduce weight, the medication to reduce weight, all make people, they really lose weight. And once they lose weight, they get pregnant. Is there any relation between infertility, obesity, pregnancy, and your triad?
Yes, Hassan. Yes, it's very, very obvious, actually. Those patients who actually ended in your clinic, that means they are suffering the fertility problem. As you mentioned earlier, there are fat women who get married, get pregnant, and have babies one after the other, and they are still fat. All right, but they are not the group of patients that really landed in your clinic. So whenever there is a fertility question, of course, obesity has to be considered first. I mean, we know that, as you have mentioned, once you reduce the weight, they get pregnant. And we know from evidence, actually, from in ART cases, all IVF cases, patients, overweight patients, actually, they don't respond very well. They require high doses of HMGs and whatever ovulation hyperstimulation technique you use, failure rate and even implantation rate actually is lower. What we see here is a direct effect of obesity and an outcome of fertility treatment. So, not to mention, of course, the PCOS group, where actually we have seen clearly by doing bariatric surgeries, they actually respond very well after that. They get regular periods and they even get pregnant quickly after the operation. I've seen patients coming to me 4 or 5 months after bariatric surgery, women with pregnancy, despite the earlier infertility stage that she went through when she was obese without the surgery. So yes, there is a very strong correlation between fertility status and the obesity. Definitely the treatment varies, and the bottom line is to reduce weight. If you cannot achieve it with diet, exercises, which is the normal approach, then those who are morbidly obese, they can go even for the bariatric surgery, which is a good solution for them to achieve pregnancy. Pregnancy outcome, of course, as I mentioned before, it's being obese, it carries many multiple factors. I mean, I enumerated about 7 or 8, but all of them can be related to obesity itself. Not to mention if they are actually combined or complicated by diabetes or other or something else like hypertension, etc. So it is actually obesity is a profounding risk factor on fertility status as well as the perinatal outcome.
Just again to mention that if anybody wants to have a question, please write it in the chat or in the question. Maybe in the chat will be easier to get to us. Dr. Hisham has mentioned, where is the dietitian? And I want to ask Dr. Ayman about would a low salt diet help in patients who are hypertensive or potentially hypertensive or had a history of hypertension? Because this is a common advice from our doctors: don't eat salt, don't eat salt. What do you think about that?
Yeah, so the answer here is we're talking about 2 different things. So if we're talking about hypertension only, then yes, the low salt diet might help. But when we're talking about preeclampsia, when it is a placental disease, then no, there is no real correlation. The only correlation that is theoretical, that if you control your blood pressure before pregnancy, either with low salt or with anything, then you might have a lower chance of getting preeclampsia. But the only evidence that the only available evidence to decrease preeclampsia, or specifically preterm preeclampsia, is aspirin, of course, and to be started with a dose of 100 or just a low dose aspirin before 16 weeks with those patients who are at a higher risk. So the New England Journal showed that it was published in 2017. I mean, the aspirin trial, it decreases up to 60% when you start the aspirin. However, the low salt, as mentioned, it can help with the blood pressure, but not preeclampsia. And preeclampsia and blood pressure are like two different things. You might have chronic hypertension that is controlled, but it's not a preeclampsia. So when we have a preeclampsia, salt has nothing to do with that. If we had it already, if we wanted to prevent, theoretically only, there is no evidence that if we control the blood pressure before, then yeah, we might decrease a little bit, but there is no like strong evidence. There are some theories also about different supplements calcium supplements in people with the calcium deficiency, etc. But these are all theories. These are not based on solid evidence.
Very good. Thank you very much. Dr. Hisham, another question, because you blame the dietitian. So I'm going to send you another question for dietitian. What about this keto diet and low protein, high protein, and fasting every other day? Do you think it will help patients who are BMI more than 35, for example? Do you think this is a way to go?
Well, these are very well documented dietary regimens, and my advice to my patients, actually, if you use it for a definite period of time, that's fine. But you cannot go for a long time, like, for example, more than 6 months on keto or high protein or whatever kind of diets. Definitely for pregnant patients, I tell them, well, pregnancy is not the time to do dieting. I mean, it's the other way around. You have to eat healthy, but at the same time, not to gain to put on too much weight during pregnancy. The balanced diet is the best thing, and diet alone is not enough. Combine it with exercises. I mean, without exercise, you're not achieve anything. So half hour at least every day of exercise, 7 days a week, not just 5 days. Every day is important. I always tell them, if you miss the half hour one day, do 1 hour the second day. So this is very helpful. I find it with even PCOS patients or maybe obese, but they love to take the glucophage. They say they reduce my weight. I said it's not really the drug that reduces weight. It's your behavior, it's your diet, it's your exercise. Even their hormonal levels has been improved by doing exercise, not to look for their weight reduction. Just by doing exercise, it actually improved their hormonal levels and regularity of their periods.
I have a comment, if you allow me, about about the diet and exercise. First of all, really, I really appreciate what you mentioned, Dr. Hisham, and I just want to emphasize, really, I mean, I love this saying that the pregnancy is not the time for diet, because there is an evidence that specifically about keto diet. I was asked about that before. It might be harmful during pregnancy. So we don't want to go with that. Specific time is okay before pregnancy, but during pregnancy, the recommendation, the American guidelines, as you said, half an hour a day. They mentioned if the average is 150 minutes per week divided. And for those who are athletics, for example, if she is, I don't know, soccer player or something, then half an hour for her is nothing. Then she wants to go even for more, like for 1 hour, 2 hours. The most important thing with exercise is not to introduce a new exercise. Like she doesn't want to like gain or lift heavy weights for the first time, or to do first like jumps or something during pregnancy. So combined diet and exercise with the recommended guidelines is really the key.
This will bring me to another question to you, Dr. Ayman. Bed rest was one of the things that you might prevent preeclampsia if you are hypertensive. If you are hypertensive, they say take a bed rest, don't move, don't do exercise, and try to balance so you don't get into the problem, like what we mentioned. Because a lot of people, they will do that. And why I'm asking this question, I ask this question because a lot of doctors, they tell them go away from the salt, try to have a bed rest, don't exercise because this might increase your blood pressure. Don't get upset, don't get very excited. All this will increase your blood pressure. Just to give us a few about this
sure.
this idea.
all these talks يعني على عيني وراسي اللي بيقولوا bed rest it prevents, but there is no evidence that bed rest might decrease preeclampsia. It might decrease the blood pressure per se, but we all know that even decreasing the blood pressure is not a treatment for preeclampsia. So maybe those, I mean, whoever is giving this recommendation of bed rest, just meaning that to take it a little bit easier, I would not say bed rest. I might say just take it easier. You don't want to get yourself too stressed out in a way that your blood pressure go higher. But honestly, there is no evidence of bed rest or even low salt diet in decreasing preeclampsia. On the other hand, I'm against bed rest, even even with preeclampsia or without preeclampsia. There is nothing called strict bed rest because it might do other harms such as DVT or stroke. Those patients with preeclampsia are at a higher risk of venous thromboembolism. So I give her another risk to stay in bed, and this is proven. The other one is depression. So she might go to antepartum or postpartum depression. So I try to avoid the word bed rest. The other thing is the exercise. Exercise is not contraindicated with high blood pressure. On the other hand, it might be beneficial actually when I'm talking about low impact exercise, like for example, a very light yoga or aerobic. The only contraindications for exercise are twins and cases of placenta previa, because we don't want the heavy exercise to exacerbate the bleeding. But other than that, I cannot recall any other contraindication for those. Maybe threatened preterm labor or short cervix is also one of the contraindications, but higher blood pressure is not. In fact, those people with chronic hypertension are encouraged to do exercise. They're not encouraged to stay home. They're encouraged to go and to walk around, swim. The best exercise for pregnancy proven is swimming, and to avoid any exercise that might do direct pressure or trauma to your body. So no, honestly, I recommend light exercise with those cases of high blood pressure.
Hassan, I want to ask Ayman another point.
Sure.
You talked about the exercise, you talked about the bed rest, no bed rest, no salt restriction. What about الزعل؟ يقول لي زوجي لا يزعلني، انا دحين عندي الضغط، عندي
لا هذه انا معاهم فيها يعني هذه صراحه كلهم انا ايوه هذا بروفن مني.
فيها راندومايز كنترول ستدي ولا ما في؟
ايوه احنا الثلاثه نسوي راندومايز كنترول ترايل ونطلع بالريكومنديشن. الزعل اللي يزعل مراته ممكن يجيب لها
بريكلامسيا.
لا يرفع ضغطها يعني ممنوع.
Maybe this is the last question. One of the recommendation of diet to give 30 calories per ideal body weight, and in Saudi Arabia the ideal body weight as consensus is 60 kilogram. So if you multiply 30 by 60, it will be 1800 calories. 1800 calories is a very small amount of calories that people they will, especially if when you talk about somebody who has her weight or the BMI is more than 35, she would not be satisfied with the 1800. What would you do, Hisham, in patient with you want to decrease their diet and calories and it's not enough for them? And I can tell you that in university hospital, when we ask them to have 1800 grams, they cheat. After what you eat, let them eat, they cheat by putting cookies and chocolates and sandwiches, and they just take it whenever there is nobody. What just give us advice about diet in patients with obesity and diabetes.
No, I think 1800 calories are good. All right, they are not too low. It's not the total; it's a distribution actually of the meals. All right, and especially if you encourage this lady to take a meal or a snack every 3 hours, and you put them in total. So I mean, for example, if you have 3 meals with each one is about 400 to 500 calories, and then you have 2 snacks and each one is about 150, you come up to the 1800, more or less to 2000. Nobody can be specific, but I think it's a reasonable diet that can be accomplished for obese women. As I mentioned before, even for obese pregnant patients, you don't want her to put the 12 kilos that we ask our a normal weight woman to put on during pregnancy. I mean, for her, if she put only 4 or 5 kilograms during the whole gestation is enough. So she won't be undernourished.
I think we are finishing now. It's an hour and a half talking about diabetes, obesity, hypertension, and it's very interesting and important subject in obstetric and gynecology. In the beginning, I would like to thank the audience who are attended this webinar. Second, I want to ask Tabuk Pharmaceutical for their very nice contribution in education, the Saudi Society of OBGYN, and of course, the main thank you for the speaker, Dr. Hisham Arab and Dr. Ayman Bukhari, who gave us really very interesting and very useful information about our subject and complication during pregnancy. Thank you very much, and we will see you again, inshallah, in another webinar. Thank you. Bye-bye.
Thank you. Bye-bye.
Thank you very much. Bye-bye.